Hello, everyone. Bonjour tout le monde. My name is Sonia Boskov. I am a Research and Evaluation Associate at the Future Skills Center. Welcome and thank you so much for joining us for today's webinar. It's part of our State of Skills series, Skill Solutions for Canada's Healthcare Workforce. To situate us today, I want to begin by acknowledging that I am currently on the traditional and current Indigenous territories of many nations, including the Huron-Wendat, the Haudenosaunee, the Anishinaabe, and the Mississaugas of the New Credit. The treaties that cover these territories include the Dish with One Spoon Wampum Belt Covenant. And as our work takes place across Turtle Island, I also acknowledge that we gather on the traditional territories of many diverse Indigenous nations who have cared for these lands and waters since time immemorial. I encourage folks that are joining today's webinar to type in the chat which lands that you're joining us today and to tune in. Thank you. Before we get started, I also want to invite you to join us this Thursday, May 14th from 12 to 1 p.m. for a webinar featuring FSC project partner Access Employment. In this webinar, Cam Muser, who is the Associate Vice President of Services and Program Development at Access, will be sharing insights from the Health English Language Pro program, an initiative that's designed to support internationally educated healthcare professionals navigate Canada's healthcare system. A few agenda items to begin. This is a 60-minute webinar, and we'll be beginning with a presentation from the Diversity Institute to help set the stage and shape our discussion. This will be followed by a panel discussion and a question and answer that features the latest research from FSC-funded projects. Then we will do a closing conversation with final remarks. A reminder that today's session will be recorded and a copy will be made available to everyone who has registered. We encourage audience participation throughout today's session. Please feel free to use the chat function to comment and the Q&A function feature to ask questions. You'll see the Q&A button on the bottom of your Zoom panel. This gives us an opportunity to interact throughout the session. This is also a bilingual event. If you want to select your audio feed, you'll turn on the interpretation button on the bottom of your screen, and then you'll either select English or Français. Now it is my pleasure to introduce the first speaker for our presentation. For the opening presentation, Dr. Wendy Cukier, Professor of Entrepreneurship and Innovation at the Ted Rogers School of Management and the founder of the Diversity Institute. Thank you.
Great. It's such a pleasure to be here today, and I will try to be brief and just set the stage a little bit with some of the background research and projects that the Future Skills Center has been leading over the last few years. I want also to do a little bit of a deep dive into some of the issues around AI adoption, not just the other supply issues. So I think it's no surprise to anybody on the panel or in the audience, in fact, that Canada is facing some significant challenges with the aging population. And it's not just because general practitioners and specialists are retiring. It's also as we get older, the demands for healthcare increase, and the projected labor shortages are significant. We'll talk more about those. There are also budgetary pressures as healthcare spending increases, and frankly, government investments decline, and we're seeing aging infrastructure. Many hospitals, long-term care facilities are crumbling around us, and the Axe the Facts project seems not to have succeeded in even transitioning that aspect of healthcare to the 21st century. And there's also a wide range of changes with technology occurring with many of the supporting technologies that we rely on, and yet our digital infrastructure and skills remain low relative to other industrialized countries. And in fact, Canada's healthcare compared to other industrialized nations is increasingly um, dropping. And when we look specifically at the skill shortages, you can see that there have been there's been some growth in employment opportunities, but the vacancy rates that occur across the country are dramatic and significant, and some sectors are hit harder than others. We also see our tremendous dependence on internationally educated professionals and immigrants being challenged with changes that have been made in a very short time. We also know post-COVID, many people have left the sector, and burnout and general health are issues. And we also know that one of the challenges with bringing in internationally educated professionals is many of them are racialized, and many of them report experience of discrimination in the workplace, but also from patients. And this is particularly an issue in long-term care facilities. So when we think about where the opportunities are, we really need, and I know we'll hear more about this, but we really need to think about dealing with healthcare at the systems level. And one of the challenges we have, of course, is federalism and the way in which responsibility is fragmented. But when we think about healthcare, it isn't just a shortage of access to general practitioners, although that's clearly an issue. It's also investments in public health and prevention. It's access to specialist care, acute and emergency services. I don't know if any of you have had experience waiting for 24 hours or more for an emergency in one of our hospitals. And of course, as I get older, I'm particularly focused on long-term and palliative care and home care issues. And all of them have challenges. When we look globally at some of the best practices that have been identified, and some of the projects, frankly, that are being experimented with in Canada, we know that things like modular training, smaller bites of training can be very useful in upskilling and reskilling. We know that work integrated learning is critical, and many of our regulated professions depend on access to residencies, placements, and so on. And some countries are finding innovative ways to meet these requirements at a lower cost and more efficiently. We also know there are opportunities for online and blended learning, and there are lots of examples across Canada and also internationally. I began my career working on with the Northeastern Ontario Telehealth Network. And so the history of distance learning and innovative approaches for upskilling and reskilling in healthcare is by no means new, but the technologies available make it far more accessible, affordable, and powerful than it was in the past. And one of our biggest issues, and this is particularly true in Canada, is how we recognize prior learning and the processes and criteria for prior learning assessments and recertification of internationally educated professionals. So when we look at specifically at internationally educated healthcare professionals in Canada, there have been a number of projects that Future Skills Centre has supported, and some of them have focused on trying to better understand international practices around prior learning assessments, around testing and credentials, around competency frameworks, and of course, there's renewed attention on how we can streamline immigration and permanent residency, as well as ways to take advantage of new technological opportunities, not just for training, but frankly for credential recognition. I won't mention the agency or the province, but I was shocked to find out, for example, that in terms of international credential recognition, a lot of organizations are still doing manual one-on-one assessments as opposed to looking at pathways for approved institutions and graduates from those institutions. And there are some interesting evolving practices. But when we talk about integrating immigrant talent and we look at the global environment, I point to Ireland simply because we know that Ireland, on the one hand, has a very highly ranked healthcare system with high levels of satisfaction and access. And it also has one of the highest levels of internationally educated physicians and nurses. And they have done some very interesting things to streamline credential recognition and adaptation, flexible upskilling, and so on. And one of the things that really has stuck in my mind are the examples of immigrants coming to Canada, registering south of the border in order to get credentialed in the US and then to take advantage of the reciprocity agreements to come back to Canada. Makes no sense at all. And I think that people like to dichotomize the notion of quality against the notion of streamlining access to immigrant talent. And I would actually argue that they should not be dichotomized because we see lots of examples where 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 internationally educated professionals actually rise to a higher standard than people who are educated in Canada. One of the opportunities to actually reshape demand and supply, of course, is responsible AI adoption. And Canada is a leader in the development of technologies, and we are a laggard in the application of these technologies to support interventions, diagnosis, or even, frankly, management of healthcare records. And when we compare ourselves, again, we see that we really are leaders in terms of some science and technology advancements, but we're laggards when it comes to the use of digitization and the fact that only 29% of physicians can electronically exchange clinical records outside their practice is one of the things that is particularly noteworthy, or the fact that most of us can make an appointment to get our nails done more easily than to meet with a physician. Lots of examples we've been documenting in terms of best practices, and one of the projects that Future Skills has led with UHN has looked specifically at opportunities for AI. I won't go through these in detail other than to say the early research certainly shows that AI-based tools can improve diagnosis, can streamline treatment, and can be more accurate than things that are being done by humans. And this is coming through both in diagnostics as well as in clinical decision supports. And lots of examples, right down to robotic assisted surgery, as well as virtual nursing assistants and chatbots to make better use of people's time. When it comes to the transformation of education, we're seeing immense developments around the use of AI agents. And this is one way that we can create experiential learning without some of the costs associated with our traditional models. And so when we think about the priorities for transformation, and I know folks on the panel are going to talk about this in more detail, there are huge opportunities to rationalize the system, to standardize licensing requirements, to improve interprovincial recognition, to replace on the procurement side some of the challenges we have to actually adopting new technologies, even when healthcare institutions have the funding needed to do it. And of course, we need to mainstream health equity in everything we do. And here I mean not just access to health for equity deserving groups, but ensuring that the healthcare system is equitable in terms of how it treats its employees and particularly racialized, internationally educated professionals. There are opportunities to streamline systems with competency-based credentials, to think about how we encourage labor mobility. And there have been some interesting projects, again, that Future Skills has collaborated on, looking at how incentive structures can work to attract people to the North, for example, and also ways to transition more people into in-demand entry-level occupations. Thinking about multiple skill pathways, thinking about reskilling and upskilling and how we can move some professionals from one category into another, how we can redefine jobs. We've seen that with, for example, the expansion of practical nurses um, domains, and also in the province of Ontario, at least, expanding the practice of pharmacists and their ability to provide care. And above all, in my view, we need to think about how we can more quickly leverage technology, focusing on low risk applications and moving up to more clinical uses in order to improve access. But it really does require a systems approach. So thank you very much, and I'm really looking forward to the discussion.
Thanks so much, Wendy. And of course, I just closed my notes. I'm going to open them again. Don't worry. Thank you, everyone, for being here. And I was thinking about, as you were talking, I'm Tricia Williams, Director of Research and Evaluation at Future Skills Center, and I'm following the chat and all the great comments in here. And there's a recognition, like all of us, we have thoughts on the healthcare system. There's deep expertise in the healthcare sectors. I grew up, my mom was a registered nurse, so I grew up around my kitchen table hearing stories from the ER from her night shifts. And I know that like everyone has some personal engagement with healthcare in some way, just by virtue of living here. So I think we are looking for solutions. And I think you did a great job in kind of setting the scene and some of the issues that have been longstanding and some of the new ones, the new opportunities, as well as the new challenges. I'm thrilled that we have a great panel here to help us make sense of this. And I'm really pleased to introduce John Klein from SEIU Healthcare, Dr. Deborah Cohen from Health Workforce Canada, and Suhayl Patel from Bow Valley College. So SEIU and Bow Valley College are partners of ours, and we've been working with them on some potential solutions to address some of the issues that Wendy laid out. And then we know that Health Workforce Canada is a newer organization that offers, is thinking about the workforce in the healthcare sector, and we're really thrilled that you can be with us today, Deborah. So maybe to start out, I'm going to ask you to, say hello to everyone. I already gave your names, but say hello to the folks on the call, and maybe a bit about what your organization is doing and what you're thinking about in regards to the healthcare workforce. And we'll start with John.
Great. Pleasure to be here. Thank you for having me. Just a little brief comments about us. As you said, my name is John Klein. I'm the Secretary Treasurer at SEIU Healthcare. We are a healthcare union of 75,000 healthcare workers across the entire spectrum of healthcare. You imagine it, we represent it somewhere in Ontario and British Columbia. Little bit about our members, and it kind of complements the introduction well. We are primarily women. About 92% of our members are women, and a disproportionate number of them, in line with the trends we see in healthcare, come from equity deserving backgrounds and immigrant backgrounds, and so that is the story of our members. In addition to everything we do as a healthcare union here in Canada, one of the things that we have moved into in the last 2 or 3 years is workforce development. So we established a training center through our union. It provides both credit programs through our career college, but also non-credit courses as well. And specifically with the Future Skills Center, what we partnered on is starting to tackle the internationally educated nurses problem here in Canada. As was stated in the introduction, internationally educated healthcare professionals face long, fragmented licensing processes that can keep qualified people out of the workforce for literally years, is what we see with our members. And so, guided by the experience of our members and the experience of employer partners of ours, what we created was our IEN Career Pathway program, which really tries to intervene upon all those different pain points, and does that through a one-to-one case management system, which has been highly successful. So really happy to be here. I think all of that is underpinned by the fact that, while workforce development for unions in this type of way is very new in the Canadian context, our international union, we're a member of SEIU International, which is about 2 million members throughout North America, has a lot of experience in this space going back to 1968. And so supporting that is we're affiliated with what's called the Healthcare Career Advancement Program. It's basically a consortium of different training funds and different training centers throughout our union, throughout North America, that jointly represents about 1,000 employers and 550,000 healthcare and other members throughout North America. So a lot of severe experience in this space. We're making a real difference, and it's a pleasure to be here with the rest of the panelists.
Thanks so much, John, and really kudos to you for being a union that is thinking about, opportunities for members to upskill, grow their roles as well. And we've been happy to be partnered with you. Suhayl, you're also working on internationally trained nurses, maybe from a different perspective. So tell us what's happening with Bow Valley College in Alberta.
Yeah, happy to do so. For me, it's morning, so good morning, everyone. My name is Suhayl, and maybe I just want to start off with just expressing my gratitude to the Future Skills Center for putting this webinar on. We've been a partner for a long time, and the efforts they lead around workforce development in key areas is really appreciated, and the experience has been well received by those that we've put through programming funded by the Future Skills Center, and it's been extremely impactful. My role and responsibility at Bow Valley College, which is one of the larger community colleges in Alberta, is around developing talent for the workforce. Really simply, our mission is to take labor market signals and translate them into competency-based training for individuals and for employers. As far as our contribution to the healthcare workforce is concerned, we do a few things, I suppose. The college itself has some amazing programming in the health space, that include allied health and nursing and so on. And then in my area, we have a series of very responsive skills development opportunities for individuals in health, looking to sort of, whether it's maintain licensure or gain sort of different skills or new skills as scope sort of changes of their roles. Internationally educated health professionals are a huge focus of ours through two specific projects, I would say. Number one, through the Future Skills Center, we just wrapped up a project not too long ago where we focused on two key priorities in Alberta around serving the health needs of individuals, and those two areas are acute care, particularly in the rural and remote settings, and then continuing care, right? And continuing care is a problem everywhere. And so, working with the Future Skills Center to, either develop the skills in continuing or rural care for individuals that don't have those skills. These are individuals from abroad, but then also those who have skills in that space, continuing care, acute care. How do we expedite those skills so that they can, transition into the workforce a lot quicker? The other project that we have, which has been wildly successful, is through ESDC. We have an internationally educated registered nurse foreign credential recognition program. It's, I think we're sitting closely at about 400 individuals in the last 2.5 years going through this program and translating into the workforce. As far as what we're thinking about sort of future forward as a college and I guess as a department as well, is we fully recognize the health challenges that exist. We talk to people all the time. We hear from employers about some of their pains. We hear from potential patients as well about what we're doing to help alleviate some of these struggles. And so one of our big focuses is going to be a healthcare center of excellence, sort of moving forward to really address this exact gap that we're talking about.
Thanks so much, Suhayl. And it's really remarkable, to think about all, like you said, pointing out the continuing care needs across the country. That I'm like, 400 isn't enough, and yet it's great, you know? But yeah, I hear you. Deborah, we're so thankful that you can be here. We haven't worked directly with Health Workforce Canada, but we know the issues we're talking about today are like the bread and butter of your organization. So this is why we're particularly glad to have you here. Can you tell us from where you sit, like tell us a little bit about Health Workforce Canada and what are the issues you're seeing or some of the ways you're approaching the issue?
Sure. Thanks, Tricia. It's lovely to be here. Thank you so much for the invitation. My name is Deborah Cohen. I am the Chief Operating Officer with this new organization. We're only just 2 and a bit years old. And we were born out of this for federal, provincial, territorial recognition that we need a different approach to planning for our health workforce over the long term, right? We see traditionally, for those of us who've been in this field for several decades, there are boom and bust cycles that we go through based on all of the realities, politics, economy, and so on. And part of our challenge in a federated system is to maintain the course and to try to get away from those boom and bust cycles to the extent that we can within the context that we exist within in Canada. This organization services and supports governments, unions, employers, health professions, academia, the collective of people that are really interested in advancing the agenda and who hold a lever for change. The truth is, as Wendy talked about the challenges, really what she was talking about is health workforce as a wicked problem, right? For those academics who are systems theorists, everyone knows a wicked problem is something that is really resistant to change and no one organization can fix it. And so the idea is, how do we work together across the system, co-designing and everyone pulling their respective levers for change to move things forward? I'll talk a little bit more later about some of the details, but one of the approaches that we have as an organization is to recognize that transformation change doesn't happen unless you've got 2 main ingredients. The first ingredient is a strong evidence base. You need good data, you need good tools, you need good models, you need all of those things to create change. But we also know that evidence alone is not enough to get things to change, right? That's just never been true and it never will be. The second part of our ingredient is around people change leadership. It's all about getting out there, working together, building trust, trying things, and innovating and co-designing as we go along, because no single organization can build the solution to fix the problem. So these are the kinds of things that we orient ourselves around. And when we think about the internationally educated health workforce, of course, that issue is a part of a much bigger and wickeder issue. And when we think about it, we have to think about it in the context of how are we supporting the pipelines and the equity-driven mandates for supporting IEHPs in the system. And we also have to think about how it fits in with the broader pictures around retention, equity, the domestic supply, meeting the needs of populations, and so on. So those are sort of the big issues that we'll focus on.
No, I'm glad you brought it to the issue of retention. I do want to, and I'm glad people are starting to write in comments. So Felix had posed a question about, we're talking only about nurses. What about the doctors? And just to clarify, this is not just about nurses, although we happen to have 2 nurse-focused programs here on the panel. But I think all of us are thinking about the whole range of healthcare sector workers, including personal support workers, up to doctors and physician assistants and pharmacists, and the whole range of healthcare workers. And I like particularly that you mentioned retention, Deborah, because I think I'll move into the second question, and maybe we'll go in reverse order. But I think one of the things we're aware of is, yes, this is about skills, this is opportunities to upskill, but it isn't only about skills, right? We know that healthcare workers are really encountering difficult workplaces and overload caseloads. And honestly, I was hearing about this 30 years ago from my mom. So like this is, in some ways, this is not a new issue, right? So what are some of the ways that we wanted to ask a little bit about jurisdictions, because we know that it does vary province to province. Are there any provinces that are really making some bold moves in this area, that are thinking about not only recruitment, but retention, and that are really paying attention to workforce issues? Or where do we see some of the promising practices in some of the jurisdictions that we can maybe learn from? So we're just curious about what you're seeing. Let's start with you this time, Deborah.
Thank you. I would say the answer to your question about our provinces and territories focusing on both recruitment and retention, the answer is a resounding yes. I think it became very clear through the pandemic that Canada writ large suffers from a leaky bucket issue. We initially focused so much on recruiting new workers to our systems. We forgot about making sure that the environments that they work in are supportive and make them want to stay. And if you've got a leaky bucket, you're in the law of diminishing returns. There's nothing you can do. So you have to work on both. I'll tell you a couple of quick stories on a couple of different provinces in terms of some of the things that we're doing. And these just happen to be nurse specific, but there are lots and lots of different innovations that are going on across the country for other health workers. Nova Scotia and Manitoba, following COVID, pretty much every province and territory was suffering from a nursing shortage. It was one of the most active gaps in the system. And so we started as a system to watch how were the provinces going to start to solve these problems a little bit differently than the way that they had. And I think what COVID taught us was that we have to work together, right? Collaboration is key. And so both within Nova Scotia and Manitoba, they set out to solve their nursing supply issues by engaging with the governments, the regions, the employers, the education system, and the regulators. And these things were co-designed around how do we actually fix the problem and solve the nursing shortage. In Nova Scotia, they created a system where they were trying to actively recruit internationally educated from afar. In Manitoba, their approach was to say, we've already got internationally educated nurses in our system and they are not employed as nurses. So how are we going to deal with that? Irregardless, what they did was they started with data. What do we know today? What are we going to do tomorrow? And how are we going to move forward? Then they said, okay, regulatory college, can you find ways to expedite the licensure pathway? And in fact, they were able to do that. The third thing that they did was to move forward with now we've got hundreds or thousands of new internationally educated workers in the system. And then the problem became, well, hold on, some of these folks, actually a majority of these folks, require upskilling or training or bridging in some way. So instead of just abandoning the idea and saying, well, that didn't work too bad, it was an iterative set of ideas to say, how are we actively supporting our IENs who are new and being integrated into the system? And that meant job training, it meant improving confidence, it meant supportive clinical advice and cultural and language. It also meant focusing on things like housing and education, the community, and all of this stuff that goes around being a human. The last thing I will say that they did was to really focus on the realities of racism and discrimination in the field. And as much as we hate to think that in Canada that exists, it exists. And so building real plans around what you're going to do when you see discrimination and racism, how are we changing cultures within workplaces, defending and being intentional about that were all really critical components. So those are just some examples of things that are going on that balance that recruitment as well as the retention piece. And these two examples have been quite successful in both bringing nurses in and keeping nurses where they are.
Now that's great. And I think Suhayl might have thoughts to build on that. I will add, moderator's privilege, that it's really nice to see recruitment campaigns focused on recruiting from outside Canada, not necessarily taking from other provinces and moving people within the country. But Suhayl, what are your thoughts on some of this and especially that talent pool that's already here?
Yeah, so maybe I'll speak about two things again. Lots of overlap between sort of my thoughts and what we're seeing and what Deborah just spoke about. So the two things I'll say is Alberta is an interesting place, and one of the things that we've recently implemented, well, the government of Alberta has, is we have an expedited sort of licensure process for individuals that come from 9 countries, right? So we're talking India, Philippines, United States, and so on. This makes up for about 96% of the internationally educated nursing sort of population. Now, through this expedited process, you can come in, you kind of verify your credential, and then you can write your licensure exam, and theoretically you're a nurse. No, technically you're a nurse. You're an actual nurse. The challenge is that employers are struggling with that. The employers don't have the capacity to train these individuals from abroad on sort of the Canadian way of nursing, the scope of practice, the competencies required, and so on. And so you have this huge body of internationally trained nurses now that are licensed, but they cannot find They cannot find jobs. And so this is a challenge. And as part of our project for recognizing internationally educated nurses, we really didn't focus on credentials at all. Most had it. We focus on the skills that employers were talking about, namely focusing on, what does it mean to be a nurse in Canada, focusing on the competencies required in that space, and then focusing on sort of psychomotor skills. The other thing I'll say is we're working really, really closely with our health authority. So Alberta Health Services here, amazing team, great to work with, and they're going abroad to hire individuals. They're coming to the tail end of that, but they've hired hundreds of nurses recently by going abroad and finding really good candidates and then supporting them through the immigration process and then getting them settled in Canada and making sure they have jobs. Where we've sort of stepped in is initially their idea was, well, we'll find really great people and we'll hire them, we'll bring them here, and we'll make sure they have this training runway, which is yay wide. Through a relationship with them and through some ideating, we've sort of offloaded a lot of that training while they're abroad, while they're doing their applications, while they're packing their suitcases. So by the time they come to Canada, that training runway is like shrunken significantly. And so that's been sort of working really, really well for us. And again, that partnership with the health authority has been extremely valuable for the health system for sure.
I love hearing about this, like government's on the move, making things happen. That's great. John, you've done so much at SEIU. Maybe it'd be good to share with folks around some of these issues that you've been tackling on both the recruitment and the retention, like quality of work issues that you've been focused on for your members.
Yeah, for sure. I think just piggybacking on a lot of what's been said. I mean, when we think about jurisdictional differences, our program's operating mainly in Ontario. So in terms of jurisdictional differences, while we look at other jurisdictions, we haven't had to contend so much with jurisdictional differences. But I think it goes without saying, just like high level, we need to reduce duplication between the provinces, and we need to move towards greater labor mobility for healthcare professionals across Canada, for sure. Um, just maybe piggybacking a little bit off what Deborah raised around some of the differences between, recruiting externally versus, internally for different provinces. I think something interesting that, we found, and kind of building on my opening comments about who our members are. I mean, we represent 75,000 members. And so when we think about, folks, just even looking narrowly in the nursing field, which is where our program's focused on, we have a nursing shortage, as we've said. But we know that Canada has thousands of internationally trained nurses with valuable clinical experience, and the system now just underutilizes their talent. A good example of that is like the lead in to creating our IEN Career Pathway program that we partnered with Future Skills Center on. We did a limited survey of just our members in long-term care, and we identified 550 people in 48 hours that are internationally educated nurses that aren't licensed for a variety of reasons. So when you think about that nursing shortage and you think about the opportunities, that just in a little microcosm demonstrates what the potential is with some systemic change to help get those people to where they need to be and to realize their full potential, in the healthcare space. And our training center is very much focused on career laddering opportunities, which is part of what our IEN career pathway program is designed to do. But I think if I wanted to drill in on specifics, looking at different, jurisdictional examples and where I think we need to move the needle is I think we need jurisdictions, one, to enhance competency-based licensing. And I think if you asked a lot of jurisdictions, including Ontario, whether they do competency-based licensing, I think they would say they do. I disagree on that. I think to some extent, perhaps, but I think they need to enhance that. I think obviously they need to create clearer and more transparent pathways for applicants. It's very, very confusing and cost intensive for folks. They need to expand bridging and supervised practice opportunities. I mean, we talked briefly about like the employer role in this, but a big part of it's, yeah, let's get them a job. And that's what we're focused on. But the other part of it is like a lot of them struggle to get these supervised practice opportunities when they fail the evidence of practice requirements. And then again, underpinning what's already been said, stronger workplace integration within supports from employers. This is hard, particularly for domestic applicants that are, balancing family, the cost, all that kind of stuff. How do we create wraparound supports and real support systems to help them succeed? And that's what our program's focused on. And I think if we continue to get other stakeholders involved and get them like-minded on these issues, I think we'll all be able to collectively make a big difference. Because I think the comment on this being a wicked problem is exactly right. We're not going to solve it in isolation, nor is anybody else. It's really about stakeholders coming together and starting to think about systems change. And if we're able to do that, we're going to have a real impact.
That felt like a mic drop moment, but you're absolutely right. I saw Suhayl nodding vigorously. And, that competency-based licensing, as you were talking about that, I'm like, okay, what are my prep question is something about promising best practices, but I'm like, not even promising. Like, what is the equivalent of Axe the Facts where everyone's like, yes, there's no way doctors should be faxing prescriptions. We're not going to go into that. But like, what is the obvious things that we're like, what are the things that we just need to do in 2026 that we know are effective and that we can double down on? And I think you started to allude to some. Do you want to jump in on this, Suhayl?
Yeah, I think the one thing I'll mention, at least from our side, yeah, so maybe I think the challenge that we face, to be fair, and I'm sure a lot of organizations or institutions, when trying to develop or skill up the next generation of healthcare workers, is this idea of like a clinical preceptorship as part of a requirement. If you talk to sort of any nurses, for example, hey, would you be willing to take on a clinical sort of student placement? I'm overworked already. There's no way I'm taking on more work, and so we need to find a bit of a solution to that. What we've done in the absence of as many, either as many clinical placements or as many hours for clinical placements, is the idea of really going hard with simulation, right? And we've sought and received approval for replacing, I think upwards of 30% of clinical placement hours with simulation hours. And the benefit has been amazing. First of all, the students get those clinical hours. But the second one is that when you do a clinical placement, for example, in continuing care, your entire focus for, those weeks or months is just continuing care. You don't get to touch anything in acute care. You don't get to touch anything in primary care. You don't get to do anything in recovery care. And so you're kind of just focused on in that one area. With simulation, you can have a clinical simulation, a continuing care simulation. You can have a simulation in acute care and so on and so forth. And so that's been, again, really, really great for us. But that doesn't remove the need for a clinical preceptorship. It's a part of the solution that alleviates at least some of that burden or some of the challenges as it relates to clinical sort of preceptorships.
No, that's such a good point. And you're right that, we have certain sectors that are really lend themselves, especially to that kind of hands-on learning. And we know that medical field is one of them, health field. Deborah, I wonder if we can turn to you. And there's a number of questions in here around, like, yes, we need immigration, but we also have people in Canada looking for opportunities. We have Canadians who maybe want to join these roles, whether younger or maybe, earlier in their career. What are your thoughts? What are you guys talking about at Health Workforce Canada about kind of like other populations groups who might benefit from opportunities in the health workforce?
Well, I think that it's a fantastic question. The reality is that um, we have to be careful with our narratives, right? So through COVID, we watched as a country as our health workforce became our heroes. We went out and we banged our pots and pans together. It was the first time in Canada I'd ever seen just this super support for a health workforce that is there. But as the pandemic progressed, we watched our heroes become burned out and exhausted, devastated, and then leave the system. And we are now acting to correct that. The unintended consequence of the narrative that health work is hard and causes you to burn out and super stressful is that the next generation of people who are coming up through the system will not want to go into the healthcare system. They will prefer jobs in AI. They will prefer jobs in tech. They will prefer jobs where they can actually sleep through the night every single night. So these are our realities. There's an awful lot that we don't talk about in our health workforce, in care delivery, that is incredibly inspiring and returns massive reward to our health workers. And I saw in the chat something about that human connection and the value that we get by providing and receiving care from human beings. That is a tangible, significant thing, but we don't talk about those things. So one of the realities is I think we have to be careful with our narratives as we think about what are we teaching the next generation about what it is like to work in healthcare. A second thing that I want to talk about quickly is the importance of data. I'm an epidemiologist by training. It is so easy to create and design systems absent of data. We talked about, John, you talked about wanting to move towards skills-based planning. Right now, what we do is roles-based planning, right? And when we move towards skills-based planning, I think conceptually a lot of people can say, yeah, that makes more sense. Why don't we have a whole range of health providers that can provide those things and then figure out what the team might look like in any particular place? But the data is missing, right? Who does what, who can do what, how do you interoperate those things? And so we have to think about, as we prepare to educate the next generation, how are we educating them? Are we educating them strictly in a roles-based capacity? Or are we teaching a set of skills with overlap so that they can interoperate and form different care teams as needed? And those are conversations we need to have.
That's great. I want to give John a chance to jump in on this conversation, and then I'm going to go to one last round of questions.
Yeah, I think those are, great points. And I think, one of the things I just wanted to raise up on recruitment and retention specifically is, and I think it feeds into what you were just saying, Deborah, but I think, moving into, I think the system, and particularly during the pandemic, and I've said this to government folks a few times, is it seems geared towards quantity over quality. It's really about like how do we get the most people possible into healthcare so that we can announce a number and feel good about it. But the consequence of that we see real time with our members is, part of the challenge is recruitment and retention, but one of the biggest challenges is early career attrition. Early career attrition is very, very high, particularly for PSWs in our union. We looked a couple of years ago that, about 50% of PSWs will leave in their first 2 years. That's like what we see within our membership, right? And you see different stats come out from government. But I think early career attrition is I think partially a training gap to the extent that we have to prepare people more adequately for the realities of the job, whether it's simulation space like that was raised up earlier, but really drilling down on getting them prepared for the realities of the job and not the romanticized, version of what people think nursing is or PSW work is. Like, that's definitely part of it is we really have to drill down on getting those people really acclimatized to what the realities of the job are. But the other piece of it too is being more intentional on the front end on recruiting the right people that are suited for healthcare. Not everybody is suited for healthcare. And one of the things that we're looking, and it goes into the data point, is starting to think about how do we vet people differently at our training center to make sure that for their benefit and for the system's benefit and for the patient's benefit, that we're recruiting the right people that are suited for the work, that are going to be happy in the work, that are going to stick around. And then we're layering obviously wraparound supports, and we're layering in there, making sure that we have micro credentialing and all that great stuff that we're doing at the training center. But I think if we don't figure that out, we're always going to have this recruitment and retention issue. It's never going to correct itself, and you're not going to fund your way out of it. It's just you can throw as much money government as they want at it. If you don't address those real gaps, you're not going to have the impact that's desired.
And importantly, I add yes to all of what you said, and importantly, also make sure that there's decent wages for this kind of work. That is really hard. It is skilled. It is important labor, and we see this across, the care economy, right? Including in childcare and kind of
Yeah.
supportive professions that are going to be fundamental to everyone we need in our economy
Yeah,
going
and I think
forward.
just building on that, just really quickly, sorry to interrupt, but like with our, again, our membership, 92% female, disproportionately equity deserving. Healthcare, like occupational segregation in healthcare is rampant. These roles they're gendered, they're racialized, they're everything. And it really, it keeps wages, it's designed to keep wages low, benefits minimal, and that has an impact. If we want these careers to be family sustaining, then there has to be intention to do that with wages and benefits and everything that workload and everything that comes along with that. And if we don't figure that out, we're never going to solve this problem.
It's in everyone's interest to figure that out, right? We have to find that. Um, this is great. I love the conversation, and there's some more questions coming in, and there's a couple that have to do with, there was one here about Bow Valley's AI expertise. So I had to put you on the spot, but it made me think, Wendy mentioned that in her opening presentation about the opportunities for technology and AI, whether it's in training delivery or in rethinking about healthcare. So I'd love to hear maybe in our final few minutes, because I'm learning to leave time for everyone to do the survey, because I really want everyone to do the survey if you're listening. But what do you see as some of is there any opportunity in this? Canadians are famously a little bit hesitant. We're a little bit not trusting of AI systems. But is there opportunity in this moment either to streamline licensing or to accelerate, the training or the identification of who's most suited to, the sectors? Or what are some of the opportunities you see? And you may mention risks too. I'm not adverse to hearing risks, but let's start with you, Suhayl.
That's a great question. So, I think as far as like the core skills of, health professionals, particularly nurses, let's say, or healthcare aides, although we do use AI, but not specifically for their sort of clinical skills, we use them for some of the administrative jobs or administrative tasks. We sort of teach them on AI, in those areas. But we're working with the system right now to figure out, well, how is it actually used and how can we do it in a safe manner? And so there's a lot of things that have to be put into place before we can actually implement it. One other thing that's important, I think, to mention on our end is we have a product that we offer for mainly right now it's continuing care facilities, to help maintain sort of, the competencies required by the government on a yearly basis. And so we use an AI within that platform to help scrape or sort of audit the competencies. And then when something sort of changes, it sort of informs the platform, and then we adjust the training accordingly. So although it's not necessarily it's not touching individuals, or AI is not touching individuals, on the floor in the hospitals and so on. It is top of mind for us, and we're working towards something.
All right. John, and then we'll let Deborah have the last word.
Sounds good. I think AI, I mean, we could probably do a whole session on AI. There's a lot to unpack there. But I mean, what I'll say about AI, generally is when I hear a lot of stakeholders talk with me about AI, it's about bending the cost curve on things and becoming more efficient. And I think AI is interesting. I think there's definitely a role for it. I'm not quite sure yet what that role is because I think one of the interesting things for us dealing with internationally educated healthcare professionals is one of the most successful things, in terms of a best practice that we've seen in our program is our one-to-one case management system, where we have an individual that's coaching people, walking them through one-to-one. That cannot be replicated through AI. And it's interesting. It's both the most successful component of it, I think. But on the other hand, with a lot of stakeholders and employers, it's while they recognize the benefits of it, they're not necessarily a fan of it because it's cost intensive, it's human resources intensive, right? But at the same time, it's also what has allowed us to move people through this program more efficiently and help them succeed. And I haven't figured out yet how AI replicates that, and I'm not convinced it can. And so I think it's like for me, it's definitely a good tool. It's valuable. We should figure out how to integrate it. But I think it would be a mistake to look at it as a holistic solution to everything that ails us, because I think it could very quickly become something that becomes our most significant pain point.
No, I couldn't agree with you more. And I would say that really resonates with other interventions we have in other sectors, that is a really important and critical component. And not everything will necessarily be taken or displaced by AI. Deborah, what are you thinking about AI at Health Workforce Canada?
Yeah, it's certainly a topic of conversation, isn't it, around the world? This is a transformational reality for us. I think from my perspective, the fact is AI is coming whether we like it or not, and we have to find ways to work with it. We have to think about AI as a tool. AI is not intended to replace human beings, but to create enhancements to what humans can do. I heard a great quote that AI will not replace physicians, but physicians that don't use AI may be replaced. So these are enablers and tools. And I think as we start to embrace that, we have to look at risk, but we also have to look at how can we use these tools in credible, capable ways clinically to create efficiencies. And my personal passion is how do we use AI to share knowledge? At Health Workforce Canada, we've developed an AI-driven digital front door, and you can now go in to this digital front door and just ask it any question that you like in English or in French, and it will give you a credible answer about what's going on in the country based on a repository of credible knowledge that we hold within Canada. That's real-time information that you might just need at a moment's notice. Now you can work with AI to develop that kind of information like that. Those are the kinds of tools that we need to use. We need to recognize its limitations, but I really think we need to keep our minds open and embrace this. It's coming whether we like it or not.
Great. What a great panel. There's never enough time. We do this so quickly to keep the minimal time on people's calendars, but I want to thank each of you for bringing your expertise, your passion, and your dedication to this conversation. And may all of you not have to see a doctor too soon, because we know they're working hard. Stay healthy and happy. And I'll turn it over to Sonia for the final closing. Thank you.
Thank you so much, Tricia, and thank you to our speakers and panelists for such a great discussion. And thank you to everyone who joined us today. We really appreciate it. Please be sure to complete the poll that pops up once you exit the Zoom window. We would really appreciate your feedback on this webinar. I encourage everyone to follow FSC on our socials. You could find us on LinkedIn, Blue Sky. And I also want to mention that we are hosting a webinar all about AI and the workplace in the first week of June. We've talked a lot about AI in today's discussion, so I just wanted to amplify that event before we log off. Registration hasn't opened yet, but keep an eye out, and we would love to see you there. Thank you so much, everyone, again. Have a beautiful afternoon, and take care.